Good morning. My name is Karen Allison. I'm an ophthalmologist at the University of Rochester, Flaum Eye Institute. I'm in charge of the glaucoma service, and I do a lot of work with population health, primarily in glaucoma, macular degeneration, and diabetes. At ARVO this year, we have a few posters and presentation. And most of these posters, they're around inequities in diagnosis and management of minority patients, marginalized patients, such as Black, Hispanics, and Native Americans, and patients of low socioeconomic groups. One of the things that we have done in, at the University of Rochester, we're looking at Monroe County and Western New York in its entirety to see the prevalence of certain diseases such as diabetes, glaucoma, macular degeneration, and also the rate of blindness from these diseases. And we have divided into Erie County, Monroe County, and then we look at the area around Syracuse. And the reason that we decided to do that is because those three counties are where the major universities are. So most of the patients in Erie County, they end up going to either University of Buffalo or University of Rochester. The patients in Monroe County end up going to University of Rochester, and the patients around Syracuse area end up going to upstate, where they have a medical center with an ophthalmology department. And what we have found in every county, there is increased rate of blindness in patients that are Black, Hispanic, and there's not a lot of data on Native Americans, unfortunately. So once we have received this data, then we look at the socioeconomic breakdowns. We look at all the different findings of inequities and that classifies as social determinants of health, such as socioeconomic factors in the economic area, the educational factors, the environmental context, of course, the health, to make sure that these patients have access to health care, access to not only health care, but good health care. And also we look at the social context, meaning the environment, the social, political scenarios around a lot of these patients. So in Western New York is quite large, and most of the patients are in the cities such as Buffalo, Rochester, and Syracuse, but in the outskirts, where in the rural areas, there's a large percentage of patients that are low socioeconomic, that have decreased access to care. So once we have identified these findings, and we have multiple posters talking about these different areas, what we decided to do was to look at the big data in our university at the Flaum Eye Institute to see what percentage of patients have these particular diseases and where these patients are coming from. First, we started with Monroe County, and then we're going to look to see what the drawing area is for our university. And we see approximately 70,000 patients per year at our university, and we are the #1 trauma center for that area. So we provide services to many patients. So because there's a lack of adequate care outside of Monroe County, what we have also implemented is what is called the Vision Van service, which we actually go into some of the rural areas, some of the communities without adequate care, and we provide services for these patients, whether in the high school, middle school, or kindergarten, and with patients with the parental consent. But we also go into community centers, into schools, churches, to do screening programs, and then once there is any identifiable diseases, then we refer them out to either their primary care or services that are close by. So with finding the prevalences of these diseases, then we can decide how best we're going to increase access to care for a lot of these populations that are not being fully treated. So once we get the data from our system to see what the breakdown is, where the gaps are in the population, then we also look at the insurances to see where the insurance gaps are, and then we can better assess where we need to go to do not only screening services but educational services to create more health equity education that are that patients can understand, and also to provide services where we can easily screen, diagnose early, and treat earlier, so that we have less patients going blind from these diseases. Once we have assessed this, then we can start doing it on a bigger scale.
While going out into these communities, do you find that there's a higher rate of eye disease or just a higher rate of untreated eye diseases?
Yeah, it's a combination. We see more, especially diabetes, and a lot of it has to do with diet, lifestyle changes. Glaucoma untreated, yes. Macular degeneration untreated, also yes. So I think access is really a big issue. We know that we have 3 levels of insurance: one that is fully insured, one that is underinsured, and one that is not insured. So the patients that are uninsured, underinsured, and uninsured, they wait until their disease is further along to go see a healthcare provider. So that is a big problem. So if we can create a screening paradigm where these patients can at least be screened once a year, even in their primary care setting or clinic setting, then at least they can be diagnosed earlier. Blindness and any decrease in vision, it's a big strain on families. It's a big strain financially. They're not able to work, cause depression, suicide, and it also leads to other diseases. So I think a big problem is the insurance. I know with the new insurance system that we have now through Obamacare, we have more patients that are insured. However, there is still at least up to about 30% of patients that are not insured because they don't qualify one or the other. The other issue is patients that have state insurance like Medicaid. They have to go to certain institutions because a lot of private doctors do not take the insurance because they're not adequately reimbursed. So sometimes it's very difficult for these patients to go to these bigger institutions. For example, University of Rochester, University of Buffalo, they may live hours away. In my clinic, I have patients come in 3, 4, 5 hours, and it's not unusual. And I'm sure it's the same way in Buffalo, it's the same way in Syracuse. So we have to find a way to provide vision care. Now, I know that there's federal qualified programs, but unfortunately, vision care is only in 30% of these federally qualified programs. So I think a lot of these vision care, eye care should be on the radar. The main causes of blindness: glaucoma, diabetes, macular degeneration, and cataract. Cataract is the #1 cause of blindness in the world. It's not the #1 cause here in America, but in certain communities it is. We still have patients walking in with these black cataracts that they've been sitting around for a long time. So even though we have all the facilities here to provide adequate cataract surgery, there's a pocket of patients that's still not receiving this. Even though we have wonderful treatment for macular degeneration, there's a pocket of patients that's not receiving it. The same thing with diabetes, same thing with glaucoma. We see patients showing up with advanced glaucoma in both eyes because no one ever diagnosed them, or explain to them that this is a disease that's not cured. So another big issue is health education that is that patients are able to understand.
What do you find has been a major factor in the increase of diseases in these underserved areas?
So I think once we look at what the issues are, then we have to figure out how can we start solving them at different layers. So I think one of the main issues with any health disease is patient education. And you have to make sure that you have culturally sensitive education and that you understand a patient's culture, language, and lifestyle. And that is helpful if you have someone from that person's background, from that person's ethnicity, that person's race. So maybe most patients are more comfortable with doctors that look like them, doctors that speak like them, or nurses, ancillary staff that look like them or speak like them, because then they feel more comfortable and they understand what their cultural behavior is. So I think that's one thing. And then once you have that, then you start creating culture sensitive language. Now we know that there is not enough doctors or nurses in a particular culture, race, or ethnicity to cover all patients at this time. But I think that's something that should be worked on so that we start creating more opportunities for doctors of different races and ethnicities. Once we do that, then we can start creating cultural sensitive, and we have to figure what that is for each culture. So we know that healthcare is only 1/5 of what's causing the problem. So we have to look at the other four. The main one is socioeconomics. The patients don't have the resources in order to do some of the things that they need to do. They don't have the money to buy. Maybe it's easier for them to buy or cheaper to buy food sources that are not nutritionally favorable. The health market may not be close by, so they go to the store at the corner and they buy food that may be processed or not as healthy, nutritional value, so that there increases their risk of different diseases, cholesterol, diabetes, hypertension. The other thing is that they live in an area maybe they're not able to go to the park to exercise. They're not able to walk safely. So creating safe space for people so that they can exercise, they can ride their bikes and walk and jog to physical activity, because we know that any type of physical activity is good for every disease that we can think about. The other is education. Create school system in their environment that is safe and that provides good education for the students that are there, because once they're educated and they're in that community, then they will want to change some of the things that's in their environment that is not safe. And the social context, obviously, we have to make it safe for them. Decrease crime, decrease drugs. These are all things that affect low socioeconomic, marginalized communities, and these are things that are beyond us, but is something that the system can change. Once we start addressing some of these issues and realize that it's not all health, then we can better understand compliance. For example, it doesn't make sense you give someone a diet of fresh fruits and vegetables if when they go to their store there's no fresh fruits and vegetables, or they're not able to afford the fresh fruits and vegetables. It doesn't matter if you give them medication if their copay is so high or it's not covered, and sometimes they're not comfortable telling you that I cannot afford it. Or if you tell them come back in 6 weeks And they're like, there's no way I can go back in 6 weeks because I just took the day off for this job to come to this appointment, and I have to work to make my rent. Or telling them if they need surgery, and they're like, I cannot have surgery because if I might have surgery, I'll be out for 2 weeks. Who's going to take care of my kids? Who's going to take care of my mother? A lot of these marginalized groups have an extended family that they have to be responsible for. So the dynamics that influence these decisions for these patients is profound. And a lot of times, if you don't understand the population or understand the nuances, it's very difficult. So I think for us to create not only patients but doctors and staff that's culturally sensitive, and find a way that we can actually assist them in a lot of these issues that they have, so that they are empowered to start eating healthy, so that they're empowered to start exercising, and empowered to start learning about their diseases. And we have to realize that you have to tell them multiple times, but tell them in a conversation way, not in a teaching way, not in a way that they feel like you're putting them down, because a lot of these patients, they're ready to realize that they have a problem, and they don't want to be spoken at, they want to be spoken to. They want to be a part of their conversation. So I think addressing a lot of these issues will help with some of the preventative aspects of a lot of these diseases, so that they can pass it on and empower the people in the communities to get involved. One of the things that we're working at University of Rochester, that's part of our preventative mechanism to a lot of these diseases, we're training what are called vision guardians. And this is something that I learned at LV Prasad. These are localized people in each community where you teach them the basics of an eye exam, basic of health screening, the basics, good nutrition. So we have a class where we have a curriculum where we teach them, and then they're the ones that go out with us in the community. They're the ones that rouse the community to come in, because I think prevention is the key. A lot of times we're looking at the end of the disease when we really should be looking at the beginning of the disease. And we should start with the young ones and help them to live more healthy lives.
Do you have any thoughts you'd like to leave us with?
Yeah, I think eye care is health care, and I think the sooner we start looking at eye care, I mean, I have more patients that tell me that they'd rather die than go blind. I see the impact it has on their families, the impact is on they get depressed, they cannot work, they have no independence. So I think it's something that we really need to focus on. Now, there's some diseases that they're rare, 1 in a million, but there's some diseases that are very common. And as I said, cataract, glaucoma, diabetes, macular degeneration, these 4 diseases are things that we really should focus on, because I really think they're connected. These are all diseases that occur as you get older. They occur in every race, and they occur in every sex. A lot of environmental factors contribute to that. Sunlight exposure, dust, smoke, diet. I tell my patients, whatever you do that's good for your heart is good for your eyes. It's the same blood going around your whole body. So I think we really need to start looking at this as healthcare and start working with other groups to make sure that we are addressing such a major part of people's human being.